Greetings from Malabar Cancer Center, the place where I'm working. It is a cancer center, it's a government cancer center situated in the northern part of Kerala. It is one of the three government cancer centers in Kerala. The other two being regional cancer center Trivandrum and Kochi Cancer Center. So coming to the topic, though lung cancer is very common in most parts of the world, early lung cancer is not so. In the US population, the screening is done in high-risk individuals. It is estimated to be around 16% of total lung cancers in numbers, and one-third of those cases are medically inoperable. And in Indian population, we are looking at around approximately 5% of total lung cancers, and how many are medically operable or inoperable, we don't have actual data. So we are dealing with an uncommon situation within lung cancer patients. So before entering the debate, let's see what is gold standard as of now for lung cancer. Gold standard is surgery. Wherever it is operable and the patient is fit for surgery, the treatment is surgery. It is lobectomy with the mediastinal lymph node dissection. That is the standard surgery. Of late, recently, there are two trials proved that segmentectomy is equivalent to lobectomy in lesions which are less than 2 cm after frozen confirmation of negativity of mediastinal and hilar lymph nodes. So this is the data from JCOG trial from Japan, where they compared between segmentectomy and lobectomy, and they got survival as high as 94% and 91% for segmentectomy and lobectomy, and 5-year PFS of 88% approximately in both arms. So this is the standard. This is the standards against which any non-surgical treatment has to be compared. Mediastinal lymph node dissection improves survival. Studies have consistently found that mediastinal lymph node dissection improves survival. This is one results from one Cochrane meta-analysis. And another trial, EchoSoft Z30 trial, compared mediastinal sampling with the mediastinal lymph node dissection. Again, at least a sampling, and wherever it is sample nodes are positive, thorough lymph node dissection is necessary to sustain the survival that we are getting in early lung cancer. Various professional bodies have recommended mediastinal lymph node dissection in lung cancer. So we cannot do away with all these recommendations just to go for non-surgical treatment in a medically fit patient. In medically inoperable, there is no debate. When the best treatment cannot be done, we can go for the next best treatment. But in a patient who is fit to undergo surgery or operable patient, where is the evidence? There is no level of evidence. 3 RCTs were planned in this topic, and the 3 are EchoSoft Z4099 from USA, the ROSEL trial of Netherlands, and the STARS trial, which was combined, conducted in USA, China, and France combined. All trials were closed for poor approval, primarily from patient refusal to undergo randomization. However, 2 of these trials, the later 2, the ROSEL trial and STARS trial, around 58 patients were enrolled, and a pooled analysis was published in Lancet of a small number of patients, 58 patients, 31 SAVR for SBRT, and 27 surgery. The results were comparable. However, there was disproportionately more deaths in the surgery arm. So, slightly improved overall survival was shown in the surgery arm. However, with the small numbers and unplanned analysis, difficult to comment. And one noteworthy finding is higher nodal recurrence in the SBRT arm. 4 patients had nodal recurrence in 3 years. Multiple retrospective comparison studies are available, though prospective trials are not available. Multiple retrospective comparison studies are available comparing surgery and SBRT, and some of them are propensity matched. And consistently, all these trials showed inferior survival with SBRT. Surgery is safer today. Radiation techniques have improved. Surgery also improved. So this is one stunning result from JCOG trial, that is Japanese trial, has recently compared lobectomy and segmentectomy. More than 1100 patients No 30-day or 90-day mortality were reported. And if you say that this is only from Japan, other parts of the world also catching up. The morbidity and mortality are significantly coming down. Minimally invasive surgery has revolutionized the field. Wax and robotic surgery reduce morbidity and mortality. These are papers published from various parts of the world showing this. Minimally invasive surgery reduces the drop in FE1 and with the comparable oncological outcomes compared to thoracotomy. So more and more patients are coming to the purview of surgery. Even those patients who are borderline for surgery are coming to the purview of surgery because of these developments. Subalveolar resections are becoming standard. Yes, I talked about the Japanese trial. There is another trial, CalGB trial, which also showed that segmentectomy, or they even included some cases of wedge resection. We'll come to that later. So, in segmentectomy is an anatomical resection where 7 to 10 nodes are typically removed, better margins compared to wedge resection, and less drop in FE1 compared to lobectomy. So this is standard in tumors less than 2 centimeter. Is wedge excision is okay for lung cancer? No, consistently studies have shown that wedge excision gives inferior results compared to lobectomy. So that is not standard. Now tell me, what surgery does SBRT resemble? SBRT resembles a wedge excision. And those who think SBRT is completely safe, you have to look into the data. SBRT can produce radiation pneumonitis up to 38% of patients and fractures and a drop in FE1 up to around 8% of patients. And yes, there are mortality. 1 to 3% mortality have been reported in various trials. Of course, you know, T and N status cannot be obtained from SBRT. So we know that even if radiologically N0 patients, you can get pathologically involved nodes in up to 30% of patients or 1/3 of patients. So those patients require adjuvant therapy. How do we get the information to give adjuvant therapy if we do not operate these patients? And adjuvant therapy, the targeted therapy and immunotherapy are improving. So how will we utilize these newer systemic treatment modalities if we do not do surgery and get these pathological findings? So, another thing I've noticed is in those trials, in most of the SBRT trials, recurrence was defined as progression at the site of tumor or radiated area. If there is a progression or new nodule appearing in another block within the same lung, or ipsilateral nodal recurrence were not considered as recurrence in SBRT arms, whereas in surgery arms, all these are considered recurrence. So there is a bias toward SBRT in the data. So we have to be very careful in assessing every data that is coming to us. And a significant number of patients have negative pathology after surgery. Those who undergo surgery without histopathological confirmation. In one trial, CalGB trial, we found that 16% of patients ultimately had a negative pathology. And many patients are undergoing SBRT without pathological confirmation for various reasons, including patient refusal or difficult to get a sample from small lesions. So, up to 1/6 of patients can have negative pathology from those who undergo SAVR or SBRT. So, essentially, we are comparing apples to oranges. Again, after treatment, up to 30% of patients can have mass-like fibrosis, which is very difficult to interpret based on with the CT scan or PET scan, requiring repeated biopsy, mental stress, financial burden, and quality of life issues. And those who think we can salvage if there is a radiation failure, really bad news is awaiting you. These patients go on to develop very bad fibrosis, which includes parenchyma and pleura. So surgery becomes difficult after radiation failure. To sum up, in many cases, histology confirmation is not available. We don't know what we are treating. Mediastin is not staged adequately. Even hilar nodes are not addressed often. In SAVR, definitely hilar nodes also not addressed. Histology guided extent of resection is not done. Definition of recurrence has a bias. Salvage surgery is difficult. Adjuvant diseases are difficult. STARS and ROSA trial, all the prospective trials just took us back to square one. So we don't have a level 1 data. To conclude, surgery is the best treatment of early stage NSCLC and remains gold standard. And we have to do it whenever the patient is fit for that. Thank you.